Welcome to Your Cases on Hold, a JBJS podcast hosted by Antonia and Andrew Schoenfeld.
Here, we discuss the science in each issue of JBJS with an additional dose of entertainment and pop culture.
Take us with you in the gym, on the commute, or most certainly, whenever your case is on hold.
Welcome back to another episode of Your Cases on Hold, number 70. We're excited to have you back here again. As always, we have some hot takes here. So all the opinions here are of myself and my Your Cases on Hold editor. I am Antonia Chen, deputy editor of Adult Reconstruction. And I have here
Andrew Schoenfeld, deputy editor for Methods.
And we're excited to be your co-host here today. This is brought to you by JBJS CME. If you haven't gotten your CME, you want to get one-stop shopping and a good place to go, JBJS CME is the way to go. Without further ado, we're going to go into the top of the pile. What Orthopedic Infectious Disease Specialists Want by Hugh et al. Angela is a wonderful ID doc in Nebraska and has some great information to share. So if you treat infections, this is what they're looking for. How can we make our lives better and treat our patients well? Challenging the concept of statistical fragility. Is there any value added by How? What's important? Arts and Humanities, The Silent Teacher by Glenn. It's permanently free. We have 3 evidence-based orthopedic articles. One is Sex and Gender Considerations in Orthopedic Research, Existing Barriers, What's Needed at Institutions and Research Departments, and How to Guide Junior Investigators and Faculty. This is a Betchold. There's also What's New in Orthopedic Rehabilitation by Castiglione et al. I'm a plug here for Don Castiglione. He's a UT Southwestern PM&R specialist, written with Dr. Jane, and they have a fantastic article here that's permanently free, and I highly recommend reading this. Improving Patient Recall Following Operative Orthopedic Trauma by Furdock et al. Education, Language, and Cultural Concordance Influence Patient-Physician Communications in Orthopedics by Diaz et al. It's also 30 days free. And finally, Manual Forearm Palpation in Acute Forearm Compartment Syndrome is Not Accurate, a cadaveric study. Interestingly enough, this is by Haidar et al. And this is one of those areas where this is what was dogma for the longest period of time, soft and compressible. And if it's not, then it's compartment syndrome. So check it out to see if it questions our current dogma with regards to acute compartment syndrome. Without further ado, we're going to start with our headlines. Dr. Schoenfeld is going to bring it in with Preoperative Nutrition Impacts Re-Tear Rate After Arthroscopic Rotator Cuff Repair by Shatar et al. And there's a commentary, there's a visual summary, and it's permanently free.
Yeah, with the compartment syndrome, it's sort of like, what lurks beneath, so to speak.
I feel a Loch Ness Monster reference coming out.
No, just, I think
all right,
Jaws.
Sounds good. Oh, Jaws, that's a good one. Touche. Okay.
All right. So now getting into this. This is obviously a study around the importance of nutrition. The recognition that nutrition is important in orthopedics goes back to, I feel like, around 1984. That's when the first studies were coming out around the importance of serum albumin in amputations. And for a really long time, it was just in that context that nutrition was talked about within our field. And I feel that, in the last 10 years or so, maybe a little bit longer, but not much longer than that, it's become increasingly recognized how important nutrition is for the success of surgical interventions across the board, be it in the context of an elective procedure, something like spine metastases or oncology surgery in general, then also in elective procedures, trauma, elective spine surgery, total joint replacement. And here we're talking about our arthroscopic rotator cuff. So this is a single center retrospective study, including patients who are probably at among the greatest risk of nutritional deficiency, those 65 years and older, who had rotator cuff tears and underwent arthroscopic repairs. They used the Geriatric Nutritional Risk Index to assess the preoperative status. They had a number of other factors that they considered, including patient demographics, clinical features, surgical characteristics. They performed a logistic regression analysis to assess the relative importance of these characteristics on outcome.
They don't go into a lot of specifics about how or what was included in the logistic regression, but they do say that variables were selected based on their performance using p-value thresholds and demonstrating significance. And they call it univariate, but essentially what they're doing are bivariable comparisons. For those who are regular listeners, you know that's not my preferred approach. And there is the potential for residual confounding, especially when you only have 143 patients. Amongst this group, the re-tear rate was 20%. That seems 28.6 patients. That seems a bit high, but I'm sure it can happen in a cohort of this type with patients age 65 and older. They do present univariate results in the results section, which is probably not something that you should invest in. The logistic regression showed that a couple of different variables, including the nutrition index, did carry a risk for re-tear, along with medial lateral tear size. The risk per millimeter is probably not translatable, principally because they just are prone to restricted clinical variation amongst the 29 patients that had experienced the re-tear. Ultimately, they feel their study includes a geriatric nutritional risk index greater than 103, may indicate good preoperative nutritional status, that less than 103 may, implicate increased risk for adverse outcomes. Would be interesting to see how this performs in other orthopedic surgical contexts. And other than that, you heard from the points that I think are cause for pause in this context. Don't love the methodologic approach. I would say that the concept is good. The methodology is probably going on hold here, however.
That's going to be a new phrase I'm going to start implementing. Pause for pause. I like that.
Yes. I'm going to make T-shirts with
Perfect.
a pause will be PAWS, and it will right.
You'll raise money for dogs and
Exactly.
cats and animals.
Exactly.
So it's a win. I like that. Play on words.
I'm the new Bob Barker. No, I don't want to be the new Bob Barker. I take that back. Never mind.
I was like,
Never mind.
We'll unwind that one. On that note, I'm going to talk about association of technology usage and decreased revision total knee arthroplasty rates for low volume surgeons using an optimal prosthesis combination analysis of 53,264 primary TKAs by McAuliffe et al. And all of our colleagues in Australia, and 30 days free. I do love it at every single time that they use the Australian Orthopedic Association National Joint Replacement Registry, or the AOANJRR, that they list the exact number of
yes, yes,
every time.
The same thing.
I was like, there's no question about how many primary total knee arthroplasties are in this study. It's always a big number, of course, because there's a lot of joints being performed there. But anyway, I do like the fact that our Australia colleagues did look at this, because a lot of people say robotics were basically made not for high volume surgeons, right? High volume surgeons have pretty predictable results and their outcomes are pretty similar. But what about people who don't use joint replacements on a regular basis? Can technology help them do a procedure they don't do often? So, for example, I don't do ACLs often. I almost never do ACLs. Like, could I use technology to help me do an ACL if I'm not doing many of them a year? So again, these studies typically look at surgeons who do high volume procedures, and they typically define that as greater than 50 or greater than 100 or greater than 200, depending on the study that you look at. And if you compare robotic versus manual in these high volume surgeons, the differences may not bear out, but do they bear out in, quote, lower volume surgeons? And the majority of surgeons in America do less than 50 joints a year. So this is a very applicable population of patients or surgeons to look at, as well as patient outcomes. So this registry was started in 2002, but the data here was obtained from January 1, 2008 to December 31 on 2022 for all primary total knees. They didn't include data prior to 2008 because at that point in time, the operating surgeon's code for a procedure was an opt-in process. So they might underestimate procedural volumes for surgeons who were operating prior to 2008. In this, they had 1,452 surgeons with TKA procedures, and 962 had their first procedure recorded since that January 1, 2008 start date. They did eliminate the first 5 years of a surgeon's practice because they wanted to diminish the influence of learning curves and experience, which I think is a nice touch because that can make a difference with regards to patients' outcomes. They also called this thing the optimal prosthesis combination in the title. Implants were limited to minimally stabilized or medial pivot design, meaning they didn't have PS. They just had either CR or medial pivot design or ultra congruent polyethylenes, fixed mobility, so not mobile bearing implants, a crosslink polyethylene, so to take away the idea of wear or lack of cross-linking, a cemented tibial component to take away any complications with regards to cementless implants, and resurfacing of the patella. Only procedures in which computer navigation, robotic assistance, or conventional instruments were used were included. They excluded something called image-derived instrumentation, which is found to have a very high complication rate in their registry, so they removed these procedures. But they did lump together computer navigation and robotic assistance together in the technology cohort, and they compared this to conventional instrumentation. Of the 962 surgeons who had that first procedure on January 1st, 677 had procedures eligible for inclusion in this analysis. And if you took away the first 5 years of practice, you were left with 457 surgeons. And these surgeons contributed 53,264 of the primary total knee procedures in that time frame. Of this breakdown, 31,536 were done with technology, and 21,728 were done with conventional. I cannot estimate this because the numbers are very precise here. Surgeon volume was assessed by the number of primary total knee arthroplasty procedures for any diagnosis and using any prosthesis in the 365 days before that particular procedure was undertaken. And the primary outcome was first revision, and this included major and minor revisions. Major revisions were defined as those that involved the insertion, removal, and or replacement of any components fixed to bone except for the patella prosthesis, and all of the revisions were considered minor. Secondary outcomes were the time to major revision and minor revisions, and they used the cumulative percentage revision and it was determined by Kaplan-Meier estimates. They used Cox proportional hazard methods to compare rates of revisions by surgeon volumes and the interaction of volume and technology. And they also did sub-analyses to see if there were differences in major and minor revisions and the influence of technology on revision rates, and with the cutoff of 100 TKB per year. If you're above 100 TK per year, you were considered high volume. If you're under 100 TK per year, considered low volume, and they even went to under 50, under 40 even. So they used all these comparisons, and they found that the all-cause revision rates, and adjusting for age and gender only, the technology TKA had a lower revision rate compared with the conventional TKA procedures. However, if you accounted for patient ASA and BMI, the differences went away. And the revision rate also did not differ between technology and conventional TKA when adjusting for age, gender, ASA, BMI, and surgeon volume. So keep that in mind when it comes to just the all-cause revision rate. The use of technology reduced the all-cause revision rate for surgeons with a volume of less than 50 total knees per year, and the rate of minor revision surgery, minor revisions for surgeons with a volume of less than 40 TKA per year. There was no interaction between surgeon volume and the rate of major revision surgery. With conventional TKA by a surgeon with 100 TKA year volume as a comparator, all cause and major revisions were significantly elevated for surgeons undertaking less than 50 and less than 100 TKA per year, respectively. In contrast, analysis of technology assistance showed no difference of rates of all cause or major revisions for surgeons undertaking less than 100 TK per year compared with 100 TK a year. Now, I'm going to read a quote from the paper that I would really like your take on. It said that, quote, the model allowing an interaction of technology usage with surgeon volume and the comparison of lower with higher volume surgeons suggests that technology-assisted total knee arthroplasty is associated with a decreased revision rate for lower volume surgeries. However, it should be noted that there was not strong evidence for this interaction, given the p-value of 0.158 for the total model, and the observed data were thus also compatible with the absence of an interaction between technology assistance and surgeon volume. I'll get your intake in just a second. So they said the key finding is that technology-assisted total knee arthroplasty was associated with a lower revision rate than conventional total knee arthroplasty for lower volume surgeons, specifically those under 50 TKAs a month, TKAs a year, I'm sorry. Why 100 as the cutoff, as their metric that they compared to? And what about the technology assist made the all-cause revision rate lower compared to conventional? Was it because of decrease in variability? Was it because someone was planning their procedures for them and they just executed the plan? It didn't include patient-reported outcomes, didn't take cost into consideration, and it didn't separate navigation from robotics. It didn't separate certain systems from one another because not all systems are identical. It also included all different implants, even though they talked about an optimal prosthesis combination. There were different implant companies that have different outcomes and variables like that. And again, this is a registry study, so there's association here, but not causation.
Okay, so there's a lot to unpack here. I think both methodologically and then more practically. We've talked about robotics and navigation and technology assisted in whichever way, and where the potential value is, and what the underlying theory is in terms of why it would diminish the potential for revisions, et cetera. I think the first thing here is when you say low volume, like what is meant by low volume, and even 50 procedures a year, to me, that's still like 4 or so a month. That's enough familiarity with like the performance of the procedure. And they set the cut at 100, right?
Yep, 100 was our cutoff. Exactly.
Yeah. So I mean, I don't really view 100 procedures as a meaningful measure for low volume. That's just people who are really doing a lot, and people who are doing some and probably enough to be competent any way you slice it. So then it's really, what is the added value of the technology? I mean, if we're talking about people who do less than 10, and you can make the person who's doing less than 10 procedures, their outcomes comparable to the person who's doing 300 procedures, then I think that's something. The measuring of the interactions, they just sort of want to be on the fence, it seems. I wonder if that, sort of was not their initial stance and they had to like pull back from it based on comments from a methodology editor or a reviewer that was knowledgeable in that regard. Because, they seem to be making that claim just based off of like the actual estimate of the p-value. And I would rather do it based off of the measure of the effect size, like how powerful is the difference when you are taking into account the interaction or not. Ultimately, at the end of the day, I think that this study there's nothing to put on hold really, but it's just telling us a lot about what we already knew about technology, I feel, just with a very large number of patients, which can provide reassurance, but I don't think it's charting new territory. Is that fair?
I think it's totally fair. That's my take on it as well, too. But interesting information.
Yeah.
Moving on to the Your Case on Hold article, patient factors associated with 10-year survival after arthroplasty for hip fracture, a population-based study in Ontario, Canada by Tohidi. There's an infographic and it's free for 30 days. Most studies typically only follow up hip fracture patients for 1 year, as 1 year mortality is pretty high after hip fractures. This study followed patients for 10 years after hip fracture to determine the long-term survival of patients after arthroplasty for hip fracture, both hemiarthroplasty and total hip arthroplasty, to determine what patient factors are associated with that outcome. And the secondary purpose of the study was to determine if there was a natural inflection point in patient age, after which the probability of long-term survival decreased more rapidly. It was a retrospective cohort study of patients greater than 60 years old. That's what they defined as their older patients. These are patients with femoral neck fracture patients, and the patients had to undergo surgery between 2002 and 2009 in Ontario, Canada. They use an Institute for Clinical Evaluative Sciences database. It's really nice because it's a captive insurance system, so you can follow patients for a long period of time. Their loss to follow-up per year of people moving out of Ontario is only 0.3% per year. That's nice and low. Not true for a lot of places in the US. They excluded patients with pathologic hip fractures greater than one procedure code on the same day, surgery performed greater than 7 days after hospital admission, and missing rurality or marginalization data. The index date was the date of surgery, and they had a look-back window of 2 years from the date of hospital admission to determine baseline comorbidities. Individuals accrued follow-up data until the end of eligibility, death, or December 31st, 2018, whichever one came first. And they estimated the association between baseline variables. Again, there's a whole bunch of normal variables that we look at, like age, sex, ASA, and a bunch of comorbidities, as well as this marginalization characteristic, surgery greater than 48 hours after surgery, and treatment year. And they use survival 10 years post-fracture using Poisson regression. And 10-year all-cause death was determined using the registered persons database, which is kind of like our Social Security death index. Restricted cubic spline functions modeled the probability of 10-year survival by age and tested whether there was an inflection point after which the probability of 10-year survivors decreased more rapidly. And then they did this in estimated 10-year survival for different patient groups. This included 20,855 Ontario residents, and they were admitted to a hospital with this non-pathological femoral neck fractures. There were a total of 19,659 patients in the final cohort. 18% of them, or 3,564 of them, were alive at 10 years post-operatively. These were the factors associated with higher likelihood of 10-year survivals after a femoral neck fracture treated with arthroplasty. Younger age, female sex, lower ASA class 1 or 2, independent living status, and an ASA class, and an absence of frailty, CHF, or dementia. Factors associated with 10-year survival were similar between patients treated with hemiarthroplasty and those who underwent total hip arthroplasties. In the oldest subset of patients, there was a slope during which the first 2 years after surgery, there was a steep drop in survival. So this is worse for males than females. So sorry for the males listening to this podcast. Approximately 1/3 of female patients greater than or equal to 90 years old died in the first year after surgery, and approximately half died by 2 years. Over half the men greater than 90 years old died in the first year after surgery, and over 2/3 died by 2 years. The cutoff threshold age was 73. That was the inflection point after which the probability of 10-year survivor decreased more rapidly in females. Estimated survival ranged from 79%, which is for a 60 to 64-year-old female who is relatively healthy, having no ASA 1 or 2, not living in a long-term care facility, no home care services, no frailty, no CHF, dementia, COPD, or diabetes. And the survival then ranged all the way down to 0.8%. And this is for a frail, greater than equal to 90-year-old male living in a long-term care institution. So interestingly enough, after controlling for all of the patient factors, there was no significant association between marginalization and risk of death. So approximately 1 in 6 patients live at least 10 years following a hip fracture. And these do give some nice baseline characteristics where you can tell a patient you're likely to live longer than that 1 or 2 years. It was nice to be able to see patients being followed longitudinally, which you can't do in the databases in the US, for example. That's hard to do. But there was no information on race, ethnicity, which might be interesting to add to this article.
Yeah, I think, as you said, this work probably can't be replicated in many other contexts because of the comprehensive and exhaustive means of capturing this population and surveying them over a 10-year time window. That's what makes this study interesting and potentially valuable. So the first thing, we know that these types of fractures almost always, and in many instances, the question is not, is there some type of frame shift in the change in patients' function, their physical function, their ability to perform activities of daily living independently? There's going to take a hit, and then it's just, do they bounce back or not? The factors that were influential of survival just struck me as these are the same factors that are going to be influential of survival in anyone, whether they have a hip fracture or not. Like, if you're under 75, you have a lower likelihood of dying in 10 years than if you're over 75. And if you're not living independently, and if you're not frail, you're going to have a less likelihood of dying. Like, there isn't anything about, these are all just factors that, no matter what, are playing into the risk of death. So it almost, to me, is sort of like the fracture itself might, in certain circumstances, accelerate things. That's why you see that 2-year physiologic stress, the individuals who can't handle that physiologic stress for whatever reason, unfortunately, those are the ones who pass away. And those who are able to deal with that stress, then they, sort of return, I think, to the normal expected trajectory. But now they're 2 years older, so their risk is going to be accelerated just by the fact that they're 2 years older, or they have more medical problems. Do you see what I'm saying? Like, this is very hard to kind of unpack.
Right. It's hard to tease out.
What we're fundamentally asking, or the question that people are asking when a patient says or a family says, now that they've had a hip fracture,
What's next?
what's their risk of near-term death?
Right.
They're asking about the effect of the hip fracture. They're not, they wouldn't accept if you just say, well, in 2 years, they'll be 2 years older, so the risk of death will invariably be higher. That's a very unfulfilling answer and would be perceived correctly as both glib and somewhat callous, right?
Agreed.
But essentially this study is not helping us understand the independent effect of a hip fracture.
Agree. Like if you're a 90-year-old living in an assisted living facility, that's already a lot of aspects that affect mortality.
Right. Whether you have a hip fracture or not.
Whether or not you have a fracture, exactly.
The counterfactual is really missing. And I know they graded it at level 3 and they're saying, well, we compared those who died to those who didn't. And that may be true. And that's why they gave it grade level 3. But
right.
what you really want to see is you take the same individual, one version of them gets a hip fracture, the other doesn't, then what happens? And that this is not able to effectively answer that. So in terms of like a epidemiologic natural history study, you have those elements and you have those points about the percent survival, 79% to 0.8% over 10 years, fine. But then the other points, they just seem somewhat like intuitive and not contextualized to the problem at hand. Saying an older patient is more likely to die, or someone with more comorbidities is more likely to die, or what about the person who has more comorbidities and a hip fracture versus more comorbidities and no hip fracture? That's really what we want to know about.
Exactly. So further studies to be done to support that.
Yeah.
Perfect. All right, let's round this out. We have some honorable mentions here. Demographics, indications, and revision rates for radial head arthroplasty. Analysis of data from the Australian Orthopedic Association National Joint Replacement Registry by Kumar et al. Does not include all the number of cases here, but trauma remained the most prevalent indication for radial head arthroplasty in Australia from 2007 to 2021. Encouragingly, revision rates were low, most notably for radial head arthroplasty that had been performed for fracture dislocation. The likelihood of revision was highest for radial head arthroplasty procedures performed for osteoarthritis and for an indication other than osteoarthritis or trauma. Non-metallic prosthesis had a higher rate of revision than metallic prosthesis. Prognosticating residual dysplasia at skeletally maturity following closed reduction for development dysplasia of the hip, a long-term study with an average 20-year follow-up by Wong et al., which is permanently free. You're talking about long-term follow-up. Patients with development dysplasia of the hip are at risk for residual acetabular dysplasia even after successful closed reduction. The aim of the study were to identify predictors of long-term outcomes in order to guide prognostication and management. Patients who were treated for DDH at 2 institutions between 1970 and 2010 had follow-up until skeletal maturity and were screened for inclusion. There were 107 people in it that were followed to skeletal maturity, 96 female, not surprising, and 11 male. And the mean follow-up was 20 years with a range from 10 to 54 years. This long-term follow-up study demonstrated that the age-specific acetabular index remains an important predictor of residual dysplasia at skeletal maturity. The proposed prognostication chart and thresholds can help guide orthopedic surgeons and parents when contemplating the use of an intervention versus surveillance to optimize long-term outcomes. Feasibility of the non-window type 3D printed porous titanium cage in posterior lumbar interbody fusions, a randomized controlled multi-center trial by Ham et al. The non-window type 3-dimensionally printed titanium cages showed equivalent clinical outcomes compared with window type cages and comparable interbody fusion rates. And the results suggest that the potential advantages of the 3D titanium cages could be optimized in the absence of a void for bone graft by providing a larger construct surface for osseointegration. And finally, safety of traditional growing rods in patients with early onset congenital scoliosis associated with type 1 split cord malformation by Sun et al. It's permanently free. Patients without neurological deficit and having a stable neurologic exam who have early onset congenital scoliosis associated with type 1 split cord malformation can safely and effectively undergo traditional growing rod surgery, followed by repeated lengthening procedures without prophylactic osseous spur excision. There you have it. Thanks for being with us today. We have more episodes for you to come as we keep bringing these episodes of JBJS.
And we keep putting the cases on hold.
We do put some of these holds, so keep delivering good stuff so we don't put you on hold.